Oh, hello. Still up?
Hello again. I'm still here.
We just have been discussing the TBI. I think you invented that.
Not exactly. I collaborated, and I'm trying to learn some Germany, and I could follow some of the slides. Actually, very beautiful work. Congratulations for all the talks.
Yeah, thank you very much. Now we go on. After we talked about diagnosis, we now talk about therapy, and you are talking about the treating keratoconus in 2021, paradigms and paradoxes. So how are you doing that in Brazil?
Thank you. I ask please to have my slides on, but the idea of putting together a talk on paradoxes and paradigms is related to the point that we need to understand when and how to do surgery in these patients. Again, this is my financial disclosures, and one of the things, for example, the International Society of Refractive Surgery, we talk about therapeutic refractive surgery, and therapeutic refractive surgery is not the same as elective refractive surgery, as we know. We need to understand and when and how to do surgery, and imaging is fundamental for that. And when you consider the paradox and paradigm, people should understand why and how they should do surgery. And the Violet June campaign has a major mission of educating people about the disease, and educating people about the disease when and how they should do surgery. We have many uh, sponsors which are in very important for us. Sometimes I'm not sure if it's clicking twice, but I'll just try to do this one, and which are important for us. So I will start with a humble wisdom that I try to interpret as best way as possible. All I know is I know nothing, and we try to interpret this as we should understand our limitations and try to be keen on improving always. So we are evolving, and we should always be evolving. As a refractive surgeon, we should understand that we evolve, and we should improve always, trying to learn how to learn, and eventually the ways to teach. Refractive surgery has made a huge contribution for the progression of keratoconus. This is related to the number of publications that we had when we had elective refractive surgery breakthrough in the world in the late 80s, early 90s. You see the number of publications, and the relevance of keratoconus really started. So we know that keratoconus has started 150 years ago by John Nottingham, and this major seminal publication has made a huge impact on the understanding of keratoconus, and it took us about a century to evolve. And the role of refractive surgery for the diagnosis, for the clinical treatment and surgical treatment, sometimes we have to face that this is an ally and also maybe an enemy, because we have multimodal imaging evolving tremendously to finalize, to detect, to screen ectasia risk, and this is very important for us to understand that. So diagnostic imaging for multimodal imaging for keratoconus is very important, and we should be keen to understand ectasia risk going beyond the detection of keratoconus. So when we screen for ectasia risk, we are not only trying to detect keratoconus. Of course, if you have keratoconus, you have a major risk for progressing keratoconus if you weaken the cornea. But when you enhance the idea of the enhanced screening for ectatic diseases, it goes beyond detecting keratoconus to the characterization of ectasia susceptibility. And this is different than when we manage patients with keratoconus prior to keratoplasty. And we definitely broke the paradigm when I did my residency My only possibility as a surgery for keratoconus was a penetrating keratoplasty, and we definitely broke this paradigm with cross-linking, corneal rings, and other procedures. But we face now some paradoxes when and how to do surgery. So the diagnosis is important for screening ectasia susceptibility, diagnosing ectasia. It's important to stage the disease and do the follow-up, as we mentioned. It's also very important for us to do the clinical management, to manage the patient the best way as possible. And the follow-up, as Michael Bellin just mentioned, is fundamental. So multimodal imaging can be done with different machines, and I was able to follow some of the talk on the correlation between the OCT and the Scheimpflug imaging, and we have to see they are complementary, as in the Placido correlation, Placido disc topography and Scheimpflug, they are going to be complementary if you know which questions you should ask that will be relevant for those data to be complementary. But we have multimodal imaging with the Pentacam today with axial length and whole eye wavefront. Of course, this is a huge progress that we see, and the data should be analyzable in such a way that we can help the patient the best way as possible. So we have to use the data to learn about the data, and situations like angle closure glaucoma can be seen in these histograms. And if you compare the population with angle closure in a normal population, and you see how the patient is behaving in terms of the distribution of each of these parameters. And of course, we have the Bellin Ambrósio enhanced ectasia display, which combines elevation, front and back surface, thickness profile, and a linear regression analysis on the D-score, which we're going to help for the detecting early or mild or susceptible cases. But we need to go beyond. Of course, Michael Bellin gave a beautiful presentation early in the morning for him in Arizona, but he was really, really very keen on the understanding what is statistically significant and a clinically significant difference between the baseline, and how come with some examples that can help you to see how important this type of understanding is. So when we manage keratoconus, we talk about the diagnosis, we talk about confirming the diagnosis, patient education, and clinical treatment. And of course, surgery is going to be indicated. And the paradox is, if we need to do surgery, we should do it as soon as possible. But if you don't need surgery, you should be really cautious on the understanding if surgery should be done. So the major possibilities that you indicate surgery are very simple. You should consider visual rehabilitation and the stability of the disease. Those are the two reasons that we would indicate surgical treatments for keratoconus. And actually, those are the two major missions that we have as physicians to help the patients with keratoconus. I would even include here first, patient education, the comfort for the patient, because here in Brazil, I see many families that are really sick, ill, because of the diagnosis of keratoconus. So we need to enhance on the understanding of the disease for the population so that they can live and make conscious decisions. And that is the first important thing that we should do as physicians. But when we consider keratoconus treatment, visual rehabilitation, as in anything in ophthalmology, would start with manifest refraction with glasses. And I started working with clinical wavefront, not even for customized refractive surgery, for custom guided ablations. I was using the whole eye wavefront data as a diagnostic tool since I came back from my fellowship in early 2003. And this is important that we have a super autorefraction, which sometimes has to be interpreted in a different way as the standard autorefraction that goes in the center. But the whole eye aberrometry can give you a lot of understanding about visual quality, but also can give you information about how to improve the manifest refraction. And we can do that with different wavefront machines. This is one of the machines that I used today, along with the eye profiler is a very good one as well, and also the WAM 700 from Essilor. One is from Zeiss and the other one from Essilor, and you can improve distance corrected visual acuity based on the manifest refraction optimization from the whole eye wavefront data. And of course, you can use this data for other diagnostic understandings as well. So when we think about treatment of keratoconus, visual rehabilitation would start with glasses and now comes with contact lenses. I would say that there is some debate, and one of the major reasons I thought it would be important for us to have a global consensus is to establish some truths. Actually, an objective truth is something that we all believe to be correct. Sometimes we can even dispute that in the future, but an objective truth about a contact lens is that it's the best way we can do for rehabilitating vision. If you properly fit a rigid gas perm contact lens, could be a scleral lens, semi-scleral lens, or even a corneal contact lens, those lenses will give you the best vision as possible. However, the contact lens do not help you in terms of progression. And if they have any opportunity to interfere on the stability of the disease, is on the opposite side, is to make the progression to occur because of the trauma, microtrauma on the ocular surface. So this is clearly well established on the global consensus that if the patient has good vision with glasses, the contact lens even should be used with more cautious because it does not halt the progression of contact lenses. And at least here in Brazil, we had a huge misunderstanding that was unfortunately promoted by some contact lens practitioners, that contact lens will be a way of stopping the progression, halting the progression of the disease. This unfortunately is not correct. That will be very good for us as physicians to have the contact lens not only providing the benefit of the best vision for the patient, but also to establish some stabilization of the disease, which unfortunately is not the case. And it was also in the consensus very clear that if the patient has good vision with glasses, we should be careful on the fitting of contact lenses. So it goes with the understanding of patient education and allergy control. Allergy control, there are no words here to emphasize how important it is. And I think we have, for example, glaucoma as a subspecialty in ophthalmology. I would say that we deserve to have keratoconus as a subspecialty of ophthalmology. And industry should see the possibility of allergy control, ocular surface optimization in patients with keratoconus, along with some possibilities to enhance cross-linking with oral supplementation with riboflavin, for example, and other factors that are coming. And of course, telling people not to rub the eye is fundamental. So we had in Brazil, we started using a B2, which is riboflavin combined with omega-3 essential fatty acids as a supplementation for keratoconus. Eye rubbing is very important, and some people would feel that it's a sine qua non, like my friend Damian Gatinel. I would say, la médecine c'est comme l'amour, ni jamais ni toujours. And that's the understanding I have for the sine qua non possibility. I think eye rubbing is a major cause for progression, but eventually if the patient has a true keratoconus with a very weak cornea, the patient may even have progression without eye rubbing. And actually the type of clinical observation that you have on the patients that have keratoconus and they are progressing, and you ask them if they are rubbing the eye, and they say, "Doctor, I'm really not rubbing the eye." And those are the patients with the worst prognosis and the more chances for going to need a keratoplasty. Of course, this has to be balanced with how truthfully is the patient, because some patients are really rubbing the eye at the time they are saying, "I don't rub the eye." So we have to be keen on, like a detective, to understand and eventually talk to the family, especially when you're talking about a kid or a teenager patient. When we think about eye rubbing This is a major consensus that we don't have any question that eye rubbing is bad for the patient and it interferes with progression. Eventually, the debate is if this is a sine qua non for ectasia progression or not. But we should agree and focus on the agreement that eye rubbing is bad. If it's very, very bad and sine qua non, I don't think it's so important. But we should focus on the message that eye rubbing is bad for the patient. And again, the wisdom of the for any cataract refractive surgeon, keratoconus specialist, that eye rubbing can cause ectasia and make keratoconus progress, I think is worthwhile to be considered, and some debate about that can be very fruitful. This is one of my penetrating keratoplasty that I had recorded during my residency, and we now do the DALK. There's a courtesy of Dr. Francis Price from Indianapolis, United States, who he's one of the best cornea surgeons, and we also can do that with the femtosecond laser. And then we started doing the shape, like the zigzag and the top hat, and other shape cuts for keratoplasty, for lamellar or for penetrating keratoplasty. But the main indication for a femtosecond laser is a corneal ring segment tunneling for an implantation. We have customized treatments, and we started doing customized treatments for keratoconus a while ago, and the combination with cross-linking, like what was proposed by John Canelopoulos as the Athens protocol, is very nice. We can also have phakic IOLs, anterior chamber or posterior chamber phakic IOLs, and the combination of corneal and intraocular lens would be very important. You can do that even with a pseudophakic IOL, but this is the therapeutic bioptics, and eventually it's very easy to indicate a posterior or anterior phakic IOL in a patient with keratoconus after a corneal procedure. If the patient has good vision with a manifest refraction, they will probably do very well with the intraocular phakic IOLs. So surgery for keratoconus is indicated to halt the progression of the disease and for visual rehabilitation. And it's very, very important that we have in our minds that refractive surgery should not be the goal for keratoconus surgery. And we published in the Brazilian Journal of Ophthalmology a few years ago the importance of separating therapeutic refractive surgery and refractive surgery as an elective procedure. And it's important that we separate those as we separate our understanding when you have a small cat and a big lion. They share over 90% of the same DNA, but if you try to pet a lion like you do with a cat, you'll be probably in big trouble. And therapeutic surgery should be seen as a procedure to rehabilitate vision. We aim for improving corrected vision. So if a patient needs a transplant and you do a therapeutic procedure so that the patient has a -7 with -3, with 20/25 -2, this will be a great result for a therapeutic procedure, but eventually a true disaster in an elective refractive surgery case. So refractive surgery should be understood in terms of the whys and the goals so that we can understand what is a success for the procedure. And if you don't realize this difference, you may be in big trouble. And of course, you have to educate the patient about what they need, what they have, and having reasonable expectations. We have to recognize the great contribution from Professor Seiler's group, Woldenstock and Eberhard Sperol from Germany, from Dresden. And this is very interesting, evolving. You see from the front page of the books that collagen cross-linking now is just corneal cross-linking, because we understand the intracellular matrix that we are talking. So corneal cross-linking is the way we should consider that. And the riboflavin UVA is just the first way we have identified to do that in the clinical setting. And I'm very sure we will have other opportunities for doing cross-linking, even with epi-off, epi-on, and we should evolve with other possibilities. So the point on the paradox is that when we indicate surgery for corneal ectasia, we should think about the need for surgery is when you have ectasia progression. So the importance of imaging for documenting, for establishing the progression, but not only for that, for providing prognosis. And I'll try to give you some of a couple of examples from my practice, how I think and how I do these clinical decisions based on the, the correct questions that we have for the imaging test that we have. It's important also that we understand that if surgery should be indicated, it should be done as soon as possible. Why? Because if progression occurs, the likelihood for success is going to be reduced. So it's important that we face the balance, the thin line between doing too soon, which is not good, and waiting too much and losing the opportunity, which is going to be important. So this is a patient that had surgery when probably surgery was not indicated. And I was able to examine in detail the data that was available for post-op. I didn't have the pre-op data. This is published recently in the JCRS, a stromal scar after cross-linking in a patient that had cross-linking and lost some vision. And it's really hard to help this patient in terms of uh, the visual habilitation. And the fellow eye is 2015, actually better than 2015. And you see the whole eye wavefront tomography, and all this data is going to be important for you to think that it may have been a fellow eye with a mild situation that should not have the treatment, but the treatment was done, and you can see in detail the case in the JCRS. But I think this was very important that I consider cross-linking a Nobel Award deserving achievement. However, we should be very, very careful when to do surgery, when to indicate surgery. The prevention is better than the cure, and we can derivate a lot of the interpretation for this, which is related to primal nocity, which is first do no harm as a physician, and indicating surgery when the patient needs is fundamental for you. So our ability to educate people so that they help you and they collaborate, they participate on the clinical decision is very important. So a couple of examples. This 17 years old, he comes with uncorrected 2040 plus, and this is corrected 2025. And you see here, he has a very asymmetric ectasia. I would say that he may meet some of the criteria of normal topography, but you can see this is the Ambrósio 2 objective scale, which is a scale that you can make it standardized so that you can make it absolute scale. And you can see like it looks like a shape of a low K keratoconus, 17 years old. But you see the biomechanical factors are not so bad. So I would say this patient has a lot of allergy, which also a fact. And in my opinion, 17 with allergy, with good vision, we should be careful on the indication for surgery. So I educated the patient about surgery. I gave them my book. I have Keratokonus and What Now, which is translated to Germany, and I hope to have this distributed for you so that you can use it if you think it's helpful for educating the patients. And the patient comes back for the follow-up after treatment. And of course, they need to have follow-up. And you can see in 3 months, this is the flattening that you can have after clinical treatment. And you see this flattening on the keratograph 5 and also on the pentacam. This is only with clinical treatment. Only with clinical treatment. And he improved the vision in both eyes with clinical treatment. No surgery. No surgery. 3 months follow-up. Of course, we need to follow these patients much longer, but you can just see here the 3-month follow-up. And I do believe that if I have done any cross-linking, even epi-on, which will be hardly defended, this 17 years old based on the Italian work should be done epi-off. This would be much worse in vision, and of course with all the post-op rehabilitation that we know about. So this is a good example that clinical with oral riboflavin, ocular surgery, allergy control, and education for not rubbing the eye can be very effective. But we have other situations. You can see even in the ABCD, you can see some regression here, which is very important to be objectively documented as well. But I have another case. This is a 13 years old, and his father told me that he is a very talented soccer player. And the father is worried because with this diagnosis of keratoconus, all the family is really worried about what is going on, and he doesn't like glasses. He doesn't need glasses. He plays well soccer, and he has a clear keratoconus in the left eye. Interestingly, the right eye, he is seeing very well. We can see topography with two scales. This is the Atlas, and this is the Ambrósio 2 scale on the keratograph. And why I'm showing you this patient makes the point of the need for advanced imaging. The first point is that the right eye, you can identify the von-Frus keratoconus or susceptible cornea based on the integration of tomography and biomechanics. You can see the TBI is on the normal range here. The cornea is a little bit on the thinner side, but this is a clear case of a normal topography, even normal tomography if you go for the Bell Ambrósio D. But the point does not stay here. This patient also can have some benefit from the improvement of the prognosis on the left eye. You see a very weak cornea, SPA1. This is the stiffness parameter in the first applanation. This is a parameter that was developed by Cynthia Roberts, Professor Cynthia Roberts from Ohio. And this is a good indicator, along with age, that the patient has a very high susceptibility for progression. This is important. The patient comes back, and he comes back a couple of months later. And you can see February and August, very recent case. And you see Kmax. And this case resonates perfectly with Dr. Bellin's presentation, because you would say, you see, Renato, it was good that we didn't do surgery, and you look at the biomechanics, it's not so important, but you see Kmax going down. But if I open here, you will see very well that the cornea unquestionably progressed. This is the subtraction map. You see even though the Kmax is reduced, you see a little more red here, and this is correlated to this. Of course, you want to see the ABCD, and you see the ABC, A and B were clearly getting worse, C a little bit, and even loss of distance correct vision. So I remember telling the family, let's do cross-linking in the left eye. I saw this patient as a second opinion already, and they decided to wait, and now I think cross-linking is scheduled for very soon. So it's important that we also see the prognosis ability. Corneal rings, we have a lot of contributions. Many colleagues from Brazil, Ricardo Guimarães, one of the first pioneers in refractive surgery, Dr. Walter Nozé, my friend Paulo Ferrara, they all contributed tremendously with the Brazilian ring. Very nice summary from Paratella. A few important concepts on rings. We can do that manually, and as a corneal surgeon, I would say it's a very nice procedure to do. You can do it with the suction, without the suction, but from all the indications of femtosecond laser in the cornea, I would say that's the only one that I cannot do the procedure without today because of the safety. And I have had experience over 10 years with the IFS, the FS200, and also Visumax. All these femtosecond lasers can do very much better work than my hands for the tunnel dissection. And this is safety and predictability and efficiency. We can combine with corneal rings with cross-linking, and this is a intertunnel cross-linking injection. I wish I had the tunnel inside of the cornea, but using some of the nice techniques that we have from from Roy Rubenfeld on the epion, we can have the molecule to go inside of the stroma and have epion cross-linking in the center. Kero ring can be customizable. We have the AS, which is a thinner to thicker with different segment arcs. And this is important because the disease is asymmetric. And we have here the need for surgery in this patient. The patient has a vision that he needs surgery, this 22 years old, because of the asymmetry, anisometropia, and aniseikonia, and we did surgery, and we confirmed from fruits in the left eye. There's a very symmetric ectasia. The whole eye wavefront data helped a little bit on the manifest refraction, but up to the limit of the irregularity. This patient had a corneal ring with the AS, and you can see the improvement that you have in the first day and improvement that you have a couple months later. And this is related to epithelial hyperplasia, epithelial modulation. I don't have the OCT here to display to you because I had to send these slides a couple of days earlier, but you can see the epithelial hyperplasia happening here, and you see the subtraction maps, the improvements that you have continuously. So it's important that we understand the paradox of keratoconus is related to a new subspecialty in ophthalmology. We have evolving paradoxes created from the paradigm shift that we had, and we have to be keen on when, how, and why to treat the surgery. Not do refractive surgery as an elective procedure in most of these patients. Of course, phakic IOLs can help those patients tremendously, but patient education is very important, and the role of multimodal imaging along with AI is very important for us to help this patient doing individualized medicine. Of course, with the wisdom in mind that we have the corpus hypocraticum, that we heal sometimes, we relieve often, but we should always comfort the patients. And sometimes it's a challenge to educate patients, sometimes a challenge to deal with the anxiety and the negativity that the patient has. But as a physician, I would say that keratoconus is a very good specialty for us to focus on, because we have a lot to help on these patients, and many patients that should be helpful. This year was very special for me with the Violet June, because we went very close to my house, the monument of the Christ in Rio de Janeiro, and we went up there with my wife, and we got the Christ on the color of our Violet June campaign. So thank you very much for your kind attention, and I really look forward to nice discussion. And again, it's a pleasure and an honor to participate with Professor Seitz in the Homburg meeting, along with Forkenzi and all the colleagues that do great work for keratoconus. Thank you.
Renato, thank you very much for this excellent overview. I think I was very impressed that the Brazilian says no rings without femtosecond laser. But I think you are not speaking for all of your colleagues.
Yes. Paulo Ferrari started the rings many years ago, and femtosecond came about 10 years after he started. So we had a lot of problems probably related to the lack of the femtosecond laser, and of course the femtosecond laser advanced tremendously the field. So you're absolutely correct.
Questions from the audience in the auditorium? Then there is a question from the online listeners. How reasonable is the vitamin B2 or riboflavin enriched diet? Are there any studies to prove that you really can do that?
Well, my mentor, Dr. Sivental, in my residency, he had a quote that was very interesting on vitamins. He says, it's much more art than science. And I think anything related to oral supplementation, even for omega-3, will be like that, because we have controversial points. It's hard to prove scientifically in a prospective study that we have a benefit. But there are some interesting evidence that oral riboflavin, if you put oral riboflavin and clinical trials. There are some good clinical trials from Minnesota, Minnesota, I think it's from Minnesota in the United States. They have a very nice setting, and I saw that in the first time in the cross-linking meeting in Zurich, and I would say it makes little harm for the patient. Pediatrics, pediatricians, they give it for treating headaches. Not a lot of them, but some of them they give oral riboflavin for treating headaches in young people. So it's very well tolerated, and it's always worth a try. But more important than oral riboflavin is telling people not to rub the eye, in my opinion. So it's a combination, and the placebo effect, along with the education for not rubbing the eye, may be what make more difference. But we need to test and to improve, to optimize our opportunities to give oral supplementation for eventually improving cross-linking and also treating allergy and reducing ocular surface inflammation, which is definitely related to the progression of the disease.
You stress that there are two goals in keratoconus treatment: the improvement of vision and to halt the disease. How about application of cross-linking versus intercorneal rings? Would you do cross-linking if the vision is bad already?
Yeah, that's a very good question. Actually, I debate with this question every day, a few times a day. We have two possible surgeries. We have cross-linking and we have the intercorneal ring implantation. So corneal ring segments are going to regularize the cornea. And we know that sometimes you have the same shape, topography and tomography, and the results are very different with the same planning. And this is related to biomechanics, this is related to other factors related to the corneal properties. So sometimes I even do the procedure combined, like I shown. But if the patient has good vision, I think cross-linking is what they should have. If the patient has a need for improvement on the vision, I would go for the cross-linking as a second procedure. And one thing that I didn't talk is doing Athens protocol after cross-linking, which is very effective. If you respect the amount of residual stromal on the top of cross-linking, is not on the posterior, it's on the top, for not having an extrusion. So, and again, you have to be careful with the amount of tissue that you remove with the excimer laser for not having the therapeutic refractive limit broken, so that safety is important. But ectasia progression and visual rehabilitation should be considered both at the same time, and you have to see every patient considering the eye that you're going to treat, both eyes together. If the patient adapts contact lens, if the patient, for example, has a progression and they are doing well with the contact lens, I would say just do cross-linking, because if you put a ring, you just can make things worse, even though you optimize and improve some regularization. But that's a one individual case situation that we have to decide.
And last question, you showed this phakic IOLs, the anterior chamber IOLs. As far as I know, they are no more on the market because they destroyed the endothelium. So we are preferring the posterior chamber toric phakic IOLs. Are you still using the anterior chamber IOLs?
No, you're right. That video was edited back 10 years ago.
Okay.
And you're absolutely right. I do posterior phakic, posterior chamber. I use ICLs and phakic for those cases. But interestingly, they don't destroy the endothelium in every patient. And if you know how to calculate the distance between the endothelium and the lens, that should be fine. And interestingly, the Corvus shown beautiful images on how the lens is far away from the cornea, and in those cases, because typically those patients have a very deep anterior chamber. But even though I have these lenses available still, I prefer phakic posterior chamber IOL. This is especially with the flow, the little holes for the aqueous flow. It's much safer, and I think is the placement for the posterior chamber is much better for the IOL.
Fully agree. Questions for Professor Ambrósio? No? So, Renato, thank you very much for getting up early and helping us with that, and you're always welcome to visit Germany once you are able to fly. Have a good day.
Thank you. It's an honor to participate. Congratulations for the great meeting. Hope to see you soon in a meeting.